able to join us, and we're hoping that others will still join us during the course of the session. So in the interest of time, we are going to introduce ourselves via the chat box. We are not going to introduce ourselves as per the norm because we have lost so much time. So can you kindly mute our audios and only use the chat box, or raise of hand if there's anything that you would like to communicate? And can you please be mindful of background noises during the session? So for our previous session, we were looking at matching drug class to pain, where we focused on the WHO ladder, and the presentation was done by Mr. Mbila from Lugongo Referral Hospital, where we looked at pain definition. We also looked at considerations inclusive of weighing benefits and side effects of drugs, and also that assessment is very key when we work with our clients in terms of matching the drug class to pain. We also looked at the issue of that when we are stopping narcotics, we gradually stop, but we don't just abruptly stop them. We had a case presentation from RFM Hospital Palliative Care Unit by Ines Nduli. She presented about a 71-year-old female who had cervical cancer. The concern was that the cancer was spreading to other organs of the body, and due to financial constraints, she could no longer go to South Africa for further assessment. The further plan was that the client was advised to take small frequent meals, and she was also experiencing constipation. So the further plan was also to give her the stool softener and the stool pusher so that she can be able to be relieved from the constipation. So today we are going to do things slightly differently. We are going to start with our case presentation instead of our didactics, as we usually do, but today we're going to start with the case presentation from Eswatini.
Good evening, colleagues. Presenting today's case is Eswatini at Hospice at Home. With our case today, we have a 44-year-old female client who's HIV positive. The problem with our client is that she is taking pain medication, sometimes overdosing, but with no relief. And also the client seems to be sometimes exaggerating the pain and cannot exactly pinpoint where the pain is. She sometimes finishes a week's dose of pain medication within 2 or 3 days. When she's given a month's dose, she sometimes finishes it within a week. So the concern is that the client might be addicted to the medication she's taking, paracodeine, as she overdoses it, and she also doesn't want an opioid change to another drug of the same or of a higher level. I'm mainly concerned because pain is subjective. There is no objective tool to measure it. You have to believe what the patient says, but also there is this concern because the client is showing signs of being addicted to the pain medication. So the client's chief complaint is that she has pain that doesn't completely subside, even with pain medication. Sometimes the pain is so severe that the patient is immobile. On assessment, the client has normal vital signs, has a normal gait, and has good adherence to art. She is well hydrated, but her skin has a darkening appearance. On her medical history, the client has had a seropositive status since February 2014. She started art at around the same time. She has no history of TB, hypertension, or diabetes. She's anemic and was enrolled in palliative care in February 2022. Coming to the client's social and family history, the client is unemployed, she's an artist, and her highest educational level was high school. She's the middle class. And I'd like to make a correction on the marital status. The client is not single but is widowed since 2020. And lifestyle habits, she has a history of alcohol taking. Well, now she doesn't confirm or deny that she has stopped taking alcohol, but she does say she used to take alcohol. And the client is not sure about any relevant health conditions as her parents passed away when she was very young. With the advanced care directives, there are no do not resuscitate orders, there's no living will, as the client hasn't reached that stage. And also there is no advanced decision to refuse treatment. The client's mental status was evaluated and the client was found to be well oriented to all spheres. However, the client has slight delusions of grandeur and is also not in talking terms with her sister, whom she is staying with in the same house. On systems review, the temperature was at a normal 36.7, the BP was 128/89, pulse 86, respirations 18 beats per minute, breaths per minute, but SpO2 couldn't be taken because we don't have an oximeter. And the pain score is 6, sometimes 7. The ECOG functionality score is at 1, sometimes 2, when the client says she is in so much pain that she cannot be mobile. Most of the time she is in bed. Then with presenting symptoms, the client has severe pain and also has mild depression and has no other symptoms. There are no relevant past medications. The current medications the client is taking is her ART regimen, which is TF, 3TC, and dolutegravir. Then she's also taking folic acid and ferrous sulfate for the anemia. Then she's also on paracodaine, diclofenac, and omeprazole. On pain assessment, the client has chronic pain, which is burning and aching in description. At a scale of 6, it is intermittent. Usually the aggravating factors are physical activity, and she is relieved by medication and rest. The client's pain affects her sleep and mobility. The effect of current medication is only partial because the client reports that the pain doesn't subside completely. And on the pain evaluation, in October, second week on the 13th, the pain was generalized on a scale of 7 severity. It was severe in intensity. And the client reported that she had the pain for months and the possible cause was activity. The treatment was paracodaine and diclofenac. But also the 2 next visits, the pain was still generalized, as the client says it's all over the body. It's a scale of now 6-ish, although sometimes she says it's at 7. So it's 6 to 7. The intensity was still severe and the possible cause is still the activity, still with the same treatment because the client refuses to be changed to a higher or to a same level drug. So progress following this in the pain medication intervention, the client reports partial pain control to a scale of 3 to 4 after taking the pain medication. So client is able to perform minor home chores and activities of daily living after having taken the pain medication. Also, the other intervention for the pain was a non-pharmacological intervention for pain, which includes yoga and also painting, listening to music, etc. So we couldn't do focused investigations as we don't have a lab. So the plan to manage this client was to continue educating the client on proper opioid use and sensitizing her on the dangers of misuse, and also to refer the client to a doctor for continuation of care, mainly with regards to the pain management. Also, the client was referred to a social worker to address social issues the client, like that the client not being in talking terms with her sister, yet they are living in the same house. To also continue promoting the use of non-pharmacological pain management techniques to relieve the pain, like continuing with yoga, art and paintings and etc. And also the last plan was to address spirituality issues of the client, as the client believes she has an ancestral calling, but she was raised in a Christian family, so she believes in both, she acknowledges both, but the problem now is that she cannot perform some of the spiritual activities which she believes pain relief, especially those which concern her ancestral side, as she believes she has an ancestral calling. So now the main problem with this client is the suspected pain addiction, but also another problem for especially the caregiver is that you cannot just withdraw pain medication for the client, as pain is subjective. It is what the patient says it is. So that is our case for today. Thank you, colleagues.
Thank you, Madam Joseph, for the lovely and clear presentation. I believe that we're all able to follow that she was presenting about the client. So at this point, colleagues, I will open an opportunity for us to ask any questions or make any comments based on the case that was presented. It could be questions that we have or any suggestions that we could give to Nonduduzo as she takes care of the client. So please unmute yourself and ask any question or make any comment. Thank you.
Okay. Maybe I have a question.
Like to make towards the case presentation.
I have a question. Thank you so much. My question can be concerning the issue of the spiritual side of the patient. Has it been helped concerning on how to move through with such spiritual beliefs that the patient has?
Please come again, Mr. Masham.
I was asking that now that the patient has also, you mentioned that she has some other spiritual issues that the patient has. So I'm seeing that the patient sometimes have has some severe pain. Maybe he cannot exactly point with where it is, which might be a sign that there is a psychogenic pain. So I wanted to know, will some of the spiritual issues been addressed? So how has it been addressed in such an issue?
All right, thank you for the question, Mr. Mahlamu. The client's spiritual issues, when addressed, the client says now she cannot do most of the ancestral rituals she is supposed to do because she is experiencing a high level of pain, which renders her immobile sometimes. So she cannot even go home and she cannot ask her sister for assistance as they are in speaking terms. So according to the client's opinion, she feels that once she has proper pain control, then she will be able to do what she is supposed to do with regards to her spirituality.
Thank you. My concern was that, especially in psychogenic pain, you discover that it cannot be well managed with drugs only. Also, the psychological care plays a major role. You discover that it will manifest when there are other aggravating or factors behind that. And now you are suspecting that he might be addicted to paracoden. There might be a challenge that maybe the patient was given the drugs when it was not necessary at that time, and then it was not utilized by the body cells to curb the pain, just because there was psychogenic pain, which might be a cause of a psychological problem the patient is going through. So I think our clinical psychologists can advise much better on how best you can deal with a psychogenic pain, especially in such a case whereby now the patient is looking for, is demanding such drugs.
Yes, Mr. Mahlangu, the client is demanding drugs. I'm also suspecting what you're suspecting, because once the client is given pain medication without the pain receptors are too weak to receive the drug, so most of it will eventually go to the addiction center. So now, even if you don't go to the client, she will call you day and night, demanding that you bring pain medication. And also with the spiritual parts, when she prefer to be attended by the social worker. But now another challenge is that we cannot see the client in her home area comfortably, because the client is always seen at the gate area. We cannot have proper access to her home to continue liberating the issues which concern her spirituality. So now the problem is, how do we withdraw, or how do we stop the pain medication without causing problems to the client? And how sure are we if we are supposed to stop the pain medication, because maybe the client is really having this pain? So that is our problem now, that the client will call day and night. After 3 days, she calls, can I have pain medication? I'm not sure if that answers your question, Mr. Mahlangu.
Thank you. Your answers. I was asking because such issues are common, so we need to be very cautious. It draws us closer then again to the issue of thorough assessment before prescription, as Mr. Mvila has been emphasizing in our previous session, and also emphasizing on the issue of reassessment now and then, every time we are doing a pain assessment. This is a sign that it's either the patient is addicted or the pain is really not well managed. So we need to go deeper. I think our guest today will address and give us some certain skills on that.
Thank you, Mr. Mahlangu, for your questions and contributions. We are seeing a hand from Mage Game, so please unmute yourself, Mage.
Thank you, Tim. Good afternoon. Mine is just to thinking about how to help this patient in terms of further assessment. I guess she's a clever patient, maybe well understanding at the same time, but I do think we need to get a doctor featured in here, because we also need to think about her liver and her kidneys. In this case, she's also on ART, and now she's taking she's overdosing in pain medication. So I think advising her, I'm not sure if she will agree going to hospital, but she does need a liver and kidney function test. And that is something maybe that will show her that what is happening, or also assist us in providing care if we are still in good track, if we still continue giving her this medication. But the fact that she's using it, she's overdosing it, is an indication serious that something is wrong. And you have, some of the things have been discussed, but mine is to say I think we do need to feature in the doctor for some tests, liver and kidney function tests, so that we could also take it from that angle. Ngiyabonga.
Thank you, Maya, for the contribution. I think it was well received on Nonduduzo's side. Do we have any questions or comments before we move on to our didactic session, colleagues? If there's anyone that we are leaving behind and they have a comment or a question, please kindly use the chat box. We will be able to respond even if you've written in the chat box. So now we're going to go, or we're going to look at our didactic presentation of the day, where we will be looking at assessing risk for opioid use disorder in palliative care. This presentation will be done by our clinical psychologist, Palliative, from the Psychiatric Center. Can you please share her slide, Mr. Ike, to you, Palliative?
Good afternoon, everyone. Can you hear me?
Yes, we can hear you.
You can hear me?
Yes.
Okay, thanks. Okay, thank you very much. Thank you for having me, even though I was just faced with internet technical issues, but I'm happy that I'm here now. Okay, let me start by introducing myself. My name is Pepile Sugati. I'm a clinical psychologist by profession. I'm practicing at the National Psychiatric Referral Hospital, and I've been recently certified as an addiction specialist, as an internal addiction specialist. So basically, I've been asked today to do a presentation on assessing the risk for opioid use disorder in palliative care. So with this presentation, what I can say within the invitation that we got is said that our slide needs to be less than 10 and is a 20-minute presentation. So basically, I've tried to just highlight the main thing when coming to the assessing and also diagnosing opioid use as an opioid use disorder. Because like if we talk about substances, we can take the whole day talking about it, or even days and months trying to unpack and make people to understand as in what are substances. Without waste of time, I will just go straight to the presentation. So basically my presentation, I will start with the introduction part, where we'll be looking at as in the definition of substance use. And we need to also know that we no longer say a patient is a substance abuser per se, but we say is a substance user. So the name of substance abuse is no longer used, but we say a patient is now in substance use. So basically, substance use is a term which describes when an individual or group of people consumes excessive amount of drugs for other than the maintenance of normal health. So we know that a patient comes or a client comes and then they've been given some medication or maybe any other drugs. So for a certain condition that they're faced with, but when they start, as in when they use that substance in an excessive amount, then we are saying that patient is now into the substance use category. And substance use begins with voluntary action of taking substances, but it can lead to changes in the structure and function of the brain. And then that shows craving. It also leads to drug-seeking behavior, which becomes virtually uncontrollable, and its use continuous despite adverse effects, meaning that even if the patient or the client has some adverse effects when coming to the drug, then they continue using it because there is this craving that they have all the time. Can you move to the next slide? Hello?
I'm hearing you, Togotel. I don't know if the Hub Center is still getting you. Mercy, do you hear Togotel?
Yes, we.
Can you move to, can you move to the next slide?
Can you move the slide to the next and put it in on a presentation mode?
Please give us a few minutes. I think we are encountering a challenge here.
We can't see the presentation. Okay. Click enable editing. Yes, click that one. Enable the editing first. Yes, click the enable editing first, so you have access to the document in completely. Yes, then you choose the presentation mode at the bottom right. I think now you can see it.
Yes.
Okay. I think you can continue.
Okay. Can you please move to the third slide? Okay, thank you very much. Then I think we can, as in my first slide, basically we're trying to define what substance use is and how people eventually get into substances. So basically, like in Eswatini, like any other country, we also have common abuse or common use substances. We have the stimulants. Stimulants basically, I think you know about it. Stimulants is basically a class of drugs that's where the message is traveling between the brain and the body. So basically, those are the drugs that, as in caffeine, those are the nicotine, those are the cocaine. Then we also have depressants. Depressants is another class of that get, especially when in pain, and they look like morphine, codeine, the methadone. I think these are the ones that you are familiar with. Then the last class of drugs that we have, like in Eswatini, is the hallucinogens. So with the hallucinogens, with basically what they do, they alter the perceptions and they alter also the thoughts, they alter the feelings of an individual. Then most cases, not even most cases, all the time, they cause like hallucination. So basically, this is an example of that is the LSD. Then can we move to the next slide? So what is, and I think the next slide talks about why do people use substances. So there are many reasons why people use substances, and basically the reasons are the same worldwide. It doesn't matter whether we are in Eswatini or we are in the States or we are in the UK. Basically, the reasons are the same, and there are many and they are complex. So from my experience working with people who are addicted into substances or who use substances, the reasons that mainly come up is because of the main one when coming to opioids is the shortcut to a sense of feeling or well-being. So this patient will say that they're having a certain pain that they're having at that time. So basically they want a shortcut to relieve the pain. Then there's also, when coming to other drugs or other substances, there's also peer pressure, there's also poverty, the social issues, poverty, more violence, more crime. There's also stress, because we cannot take away stress from everything that comes in, especially when it comes to the use or abuse of substances. There's also stress, there's also psychosocial issues that the individual is encountered with. There's also idleness, basically people saying that they're killing time because they've got nothing to do at that time. And there's also learned and copied behavior. We say people that they copy behavior from other people or they learn behavior from other people. Can you move to the next slide? Then assessing, when coming to the assessment part, the need for treatment, as in how do you know that this person has moved from the part of us using the substances? They now go to the part of getting into the addiction part, getting to the part of being addicted to the substance, especially maybe say to the opioids. How do you know this person is now dependent on this pain medication, doesn't want to live without even the pain medication? Because at times these issues, they can be psychological somehow. So an assessment, when doing an assessment, we need to have a thorough medical and psychiatric history. So we shouldn't leave the psychiatric history on the side, because you find that the people that are now abusing or using the opioids, because of a certain, now it's no longer like a physical pain per se, now it's a psychological pain and emotional pain. So basically these people, they need like use that substance to feel a relief. So we're saying that a medical and psychiatric history, a substance use history. So we need to assess for a substance use history, and evaluation of family and psychosocial support. So frequency of opioid use and route of administration, for example, oral, intravenous, intranasal, can help gauge the likelihood of severe withdrawal or possible infections, which will influence further testing and the need for counseling. So previous attempts to stop using opioids, type of treatment use and response to treatment. So you need to assess this client, you need to ask this patient all these questions about the previous history. Did they try to stop before? What happened when they tried to stop, and etc. Can you move on to the next slide? So when coming to the diagnosis part, so it gets to a point where we have to diagnose a patient with a substance use disorder. So in order for someone to be diagnosed with a substance use disorder, they need to meet a certain criteria. So we use the DSM-5, which is a Diagnostic Statistical Manual 5, when coming to the diagnosis. Then when coming to opioid, so opioid has also been classified as a diagnosis on its own. It's no longer being put under the umbrella term of a substance use. So in order for us or for anyone to diagnose someone with an opioid use disorder, they need to meet this following criteria. So basically we're saying that we know that it's a problematic pattern of opioid use when the client is using the opioid in a pattern leading to clinically significant impairment or distress, as manifested at least two of the following, occurring within a 12-month period. So basically we're saying this patient needs to be using or abusing this opioid for a period for at least 12 months. but they also need to have the following symptoms. The first one, the opioids are often taken in large amounts or over a longer period than was intended. There is a persistent desire or unsuccessful efforts to cut down or control opioid use. So we're saying the patient has tried to cut down or to stop this, as in the opioid, but they can't on their own. And three, a great deal of time is spent in activities necessary to obtain the opioid use, the opioid or recover from its effects. Can you move to the next slide? Then there's also a craving meaning that this patient as in wants, as in the opioid or at any time, the substance at any time. So the craving or strong desire or urge to use opioids. So we'll say, we'll give an example that we have given these patients that pain medication, the opioid, but they keep on wanting more and more and more. So the fifth one is the recurrent opioid use, resulting in a failure to fulfill major role or obligations at work, school, or home. So basically, the use of the medication, when it starts affecting their school, maybe school performance, or is having an effect at home or at work. Number six, a continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Number seven is an important social, occupational, or recreational activities are given up or reduced because of opioid use. So basically, if it's starting affecting you in your daily functioning, we say that maybe now it has moved from the use to a disorder per se. Can you move to the next slide? So number eight, the recurrent opioid use in situations in which it's physically hazardous, and the continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely, that is likely to have been caused or exacerbated by the substance. So basically, we're saying good thing from number 1 to number 10 or to number 9. So the patient or the client needs to meet at least 2 of the criteria to be diagnosed as to be having an opioid use disorder. So number 10, basically, we're talking about tolerance, because in substance use, there are terms that are being used like substance as intolerance. So tolerance is being defined as a need for marked increased amount of opioids to achieve an intoxication or desired effect. For example, there's this patient who's being given some pain medication. Then you know the quantity or how you're supposed to give the patient, but the patient keeps on saying, well, see, this amount no longer works for me, and they want more of it and more of it. We're saying, well, see, this patient has got to the point of the tolerance part. Well, see, they want more and more. So basically, that's how tolerance is being defined. So a marked diminished effect with continued use the same amount of an opioid. So can you move to the next slide? So basically what you need to note, because this criterion is not considered to be met for those taking opioids solely under appropriate medical supervision. So if this medication is being prescribed by a medical doctor, and is the doctor or whoever, the practitioner who is increasing the dosage, it's okay that way, because there is a reason why the dosage is being increased. But if the patient is the one who wants to increase the dosage for him or herself, that's when the tolerance part comes in. Then we have the withdrawal part. The withdrawal part, we're saying within the characteristics of opioid withdrawal syndrome, so basically refer to the criterion before. The criteria is set for opioid withdrawal. Opioids or a close related substance are taken to relieve or avoid withdrawal symptoms. So let's say this patient has been taking some opioids per se, or some pain medication. Then when they stop taking that, and then they face withdrawal symptoms, then they go back and take the opioids for the withdrawal symptoms. So what you need to note is that this criterion is not considered to be met for those individuals taking opioids solely under appropriate medical supervision. So when coming to the opioid use disorder, you need to also specify is this patient in the early remission, or is in the sustained remission, or is in the other stage. So in early remission, we're saying is after a full criteria for opioid use disorder were previously met, none of the criteria for opioid use disorder have been met for at least 3 months, but for less than 12 months, meaning this patient fits the criteria, but when coming to the duration, it doesn't meet the 12-month criteria. We can say, this patient has got an opioid use disorder, but is in early remission. Then we have got the sustained remission, which is a full criteria for opioid use disorder were previously met. None of the criteria for opioid use disorder have been met at any time during the period of 12 months or longer. So we're saying this patient is now in a sustained remission. Next slide, please. So we have the maintenance therapy, which is the maintenance phase. So basically on maintenance phase is this additional specifier is used in the individual if taking a prescribed agonist medication such as methadone or buprenorphine, and none of the criteria for opioid use disorder have been met for that class of medication. This category also applies to those individuals being maintained on a partial agonist, an agonist or antagonist, or a full antagonist such as oral naltrexone or depot naltrexone. So in a controlled environment, this additional specifier is used if the individual is in an environment where access to opioids is restricted. So basically that's the part when coming to the diagnosis of the diagnostic criteria. I know I've tried to put a lot of information in together, as I've said, like in the beginning, usually when coming to unpacking as in the diagnosis part, it can be a full day presentation per se. So in conclusion, we're saying that substance dependence is not a failure or will or strength of character, but a medical disorder that could affect any human being. So basically, when we talk about any substances or opioid use or any other substances, we say this is a chronic and relapsing disorder. So when we get these patients, then you find maybe they were abusing or they were using as in opioids or any other substance, and then they stopped, then they got back to the substance again. We need to understand this is a relapsing disorder. So people can get to the point of stopping, then relapse again into substances, and often co-occurring with other physical and mental conditions. So basically, you find that to someone with a substance use disorder, they have other co-occurring as in psychiatric conditions, like example, both depression, both anxiety, and any other mental condition. So it is a therapeutic process basically that involves behavior change, that the client needs to change his or her own behavior. And we know that behavior, the change goes in as in according to stages. So there are different stages when coming to the behavior change. We say the clients or the patients start by the pre-contemplation stage, where they see no need of changing at all. Then they get to the contemplation stage, then up until to the action phase and to the part where they eventually stop using their substances. Then psychosocial interventions are important, and especially when treating someone with a substance use disorder, because you find that there are other psychological or other psychosocial issues that has made that person to get into the point of using any other substance or abusing any substances. And often the use of substitute psychotropic medication. So basically, is not only the psychological part or psychosocial interventions. Basically, you find other patients, they need to get to the point of getting into, as in using psychotropic medication when trying to treat the addiction. So we know that as in when coming to the issue of opioids, the medication that is used in most parts, as in the treatment, we call it a medication-assisted treatment, which is the MET, which is the best option for opioid use disorder. And MET is the use of the different medication, both naltrexone, both methadone, and both buprenorphine. So unfortunately, like in the country, we don't have these medications per se, but we try as in other medication to try and as in help someone who is already into the substance use disorder. Thank you very much. I think that's the end of my presentation.
Thank you, Pepile, for the presentation. In as much as the slides were few, but I believe we covered so much ground from this presentation. And I believe that it will help us to be able to better assess the risk for opioid use disorder and the need for treatment. My colleagues this side have a few comments to make on the presentation, so I'll give this opportunity to them.
Thank you so much. Thank you so much, Dr. Petile. This was into the point, and I'm sure our colleagues will be able to at least tackle the patients they are having problems with. I like everything you said, and I wish if there was time you wouldn't even stop telling us about the assessing risk of opioid substance use disorders. I like every step of it, because we even classified you even went to a point of assessment and the diagnostic criteria. This was very, very good and to the point. And picking up on the therapeutic processes, it was excellent. And I'm sure that's where our client will need to be helped, as there is a bit of confusion with this kind of patient our sister here is having. Thank you so much, Dr. Pepile.
Okay, thank you. Okay, so I think maybe, sorry, I just another point that I just need to emphasize on, especially when coming to clients or patients that we see with substance use disorder. So I always say, these patients, as much as they're abusing, we shouldn't forget the psychological part, because some of them they are using this because there is some psychological thing that's going on, like in their lives. So when doing the assessment, let us also as in assess about the psychosocial issues that this client is facing at that time. If there is a need, like they need to see someone to try and address those psychosocial issues.
Thank you for that feedback. I think our colleague wanted to ask around that area, but you have already answered on that aspect. So thank you so much. Thank you, colleagues, for joining us for this session. We have come to the end of today's session because of time. Please click on the feedback link in our chat box so that you can be able to give us feedback on today's. And thank you for bearing with us in terms of the issues that we were having earlier, which led to the delay in the start of today's session. So please click the feedback link in the chat box. And our next session will be on the 11th of January 2023. So thank you so much for joining us today, colleagues. Have a lovely afternoon and bye. Bye.